Hi, my name's Andrew Harding. I'm from Lancaster University. For the next 5 minutes, I'm going to walk you through our presentation, lessons learnt from undertaking dementia nursing home research remotely and online during a global pandemic, tales from 2 advanced care planning implementation studies. And you can see the rest of the research team on this first slide here and my contact details down here. Okay, so I'll just give you a bit of context for both projects. Firstly, my support. Well, this study seeks to implement and evaluate a specific advanced care planning approach, which involves providing family carers with information on symptoms of advanced dementia. And then nursing home staff hold a family care conference where a formal advanced care plan is developed. It's a mixed methods pre and post study, and each site is required to undertake a number of activities, including training, learning new ACP processes and embedding these in practice, and finally undertaking the family care conferences and developing the advanced care plans. It's an international project which is taking place in Canada, the UK, including Northern Ireland, and a couple of other countries in Europe. Secondly, we've got the necessary discussion study, which is a sister project that fell out of my support. Now, this project seeks to develop and evaluate online COVID-19 relevant advanced care plan informational and training resources for family carers and care home staff. It's a mixed methods pre and post study, although it's mostly qualitative, and each site is asked to assess the training, evaluate it, and they're not expected to undertake any advanced care plans as such. Now, this study is recently concluded and ran exclusively in the UK. So I'm going to talk about 3 things. Firstly, engagement, being responsive and adding value. So what have we learnt from an implementation perspective? Well, firstly, engagement. So site engagement with necessary discussions was far more successful. We think this was because it was driven by a clear need, was a relatively short-term and light touch study design, and did not really require an advocate or a champion as such in each site, and was therefore relatively simple and easier to recruit and maintain engagement over the course of the project. However, in my support, which has a dementia focus, COVID-19 actually became a barrier in the context of a heavy study design, the requirement of an advocate or champion on the ground, and frequent delays and deprioritizing, and subsequently prolonged and meaningful engagement was harder, and we often lost sites and had to recruit new ones, and it was much harder to maintain engagement over a longer period. Being responsive. So my support actually began before the pandemic, and although we changed the project to be done completely remotely, in the first 12 months or the first period of the project and of the pandemic, we understandably had frequent delays. There were lots of challenges and unknowns for nursing homes in this period, and we think that these delays and deprioritizing, which is completely understandable by the way, made it harder to start things up again with any form of momentum. In contrast, necessary discussions was driven by a clear need. The COVID barrier in my support actually became a facilitator in necessary discussions. And there was a big overlap in staff between the 2 projects, and necessary discussions benefited from this hugely, with a study design being designed off the back of learning from my support. So it was sufficiently lighter, nimble, and more agile. Adding value. So both projects provided training and support at a key time in nursing homes. In my support, this was developed in-house at Queen's University in Belfast, and in necessary discussions, this was developed by an integrated communications company and informed by a review of existing resources. We also provided free tablets in both sites. Because of the factors already discussed relative to study aim, my support became harder to implement and embed as planned, and we're currently beginning to learn why, but I think it's fair to say that impact has been mixed. In contrast, the aim of necessary discussions was to develop and evaluate training with no expectation of sites going any further, but we've got some really good evidence of substantial impacts, including advanced care plans being developed and giving staff confidence to have these conversations, and also empowering family members to raise these issues. So lessons learnt. Well, in summary, the reasons why we think necessary discussions was more successful are as follows. the expertise of the research team who had gained experience in remote working in this context. We think the training was probably more effective, possibly more aesthetically pleasing because it was developed by an external comms company. The light touch study design and low expectation to undertake ACPs actually can, you wouldn't think this would be like that, but it actually led to some sites working on it working it into their existing practices. In contrast, my support asked people to engage with new processes and practices at a very challenging time. So we think that all of this points to the need to co-design interventions to ensure that they are practical and deliverable in each setting. The key way also to main engagement and buy-in. Finally, necessary discussions was driven by a clear need and always had momentum. In contrast, my support had less of a clear need, and once it was deprioritised, it became much harder to reprioritise it again. And very finally, this presentation summarises the UK context of the My Support study. I'm wary that it was conducted in many countries across Europe and in Canada. And the Necessary Discussions project is a sister project of My Support and provides a useful comparator because, as I say, it's a sister project and it also took place in the UK. So that's that from me. I'd love to hear from you if you're interested in this work, and my contact details are on the first slide. Thank you.